Welcome to this special webinar presented by AST and CMS, Introduction to the Kidney Care Choices Model. Today's session is also supported by AST's Kidney, Pancreas, and Transplant Administration and Quality Management Communities of Practice. Our moderator for today is Dr. Rachel Patzer, Director of Health Services Research Center at Emory University School of Medicine in Atlanta, Georgia. However, before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded and the archive will be available on the AST YouTube channel 2 to 3 business days after the live session. Please note that all of your lines have been muted for this presentation so that only the presenters can be heard clearly for the archive recording. If you have any questions for our panelists during the webinar, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer with the video recording following the session. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. Finally, when you my apologies. I will now turn the session over to our moderator, Dr. Patzer, to begin our presentation.
Great. Well, welcome everyone. Good afternoon, and thank you again to the AST for sponsoring and hosting this webinar focused on the introduction to the Kidney Care Choices Model. So I'll start with a few introductions for our speakers, and our first speaker today is Tom Duvall in the Division for the Centers for Medicare and Medicaid Services, CMMI. So Tom Duvall is the Division Director for the Division of Special Populations and Projects in the Seamless Care Models Group at the CMS Innovation Center. And in that role, he oversees 3 different payment models that are focused on improving care for beneficiaries with kidney disease, and 2 payment models focused on rural hospitals. He's worked with CMMI for 7 years, and he previously worked in Medicaid policy and financial consulting for Mercer Consulting. He received his undergraduate degree from the University of Michigan and his healthcare MBA from Johns Hopkins. Our second speaker today will be Dr. Darla Granger. Dr. Granger is a Section Chief of Transplantation and Vice Chair of Surgery at Ascension St. John's Hospital in Detroit, Michigan. She's a Clinical Associate Professor of Surgery at Wayne State University, Central Michigan University, and St. George's University. She currently serves on the ASTS and UNOS Vascularized Composite Allotransplantation Committees, serves as an ad hoc reviewer for AJT transplantation and clinical transplantation. And she completed her medical school training, general surgery residency, transplantation, and immunology and surgical infectious disease fellowships, all at the University of Minnesota. She's currently serving as a transplant provider representative to a Michigan kidney care entity. And today she's speaking about her experience with that model. So our objectives today for this webinar are really around describing the goals and policy mechanisms of the Kidney Care Choices Model, how the payment model is structured to improve the transplant process, and then providing some direct information to how transplant centers can participate in the Kidney Care Choices Model. So for a little bit of background before I introduce Tom, we know that end-stage renal disease represents about 1% of all Medicare beneficiaries, but represents more than 7% of Medicare fee-for-service payments. And historically, for these patients, the current Medicare payment system has really encouraged in-center hemodialysis and this fee-for-service payment model as the default. The first initiative by the Centers for Medicare Innovation Services was this comprehensive ESRD care model, or CEC model, which was a voluntary shared savings alternative model for provider groups. And this is really was introduced in part because of this complex patient population that we have with multiple care providers across multiple health systems for patients who have end-stage kidney failure. So the CEC model, the comprehensive ESRD care model, was in operation from March 2015 to October 21st. And that was really this alternative payment model for provider groups called the ESRD Seamless Care Organizations, again, similar to an accountable care organization that allows for providers to meet quality benchmarks for dialysis patients to receive financial bonuses proportional to savings. So broadly, this program ended, though some of the results from this have and findings from this and lessons learned have been incorporated in other models. But broadly, there were some mixed results from those models, but found that it overall found that there was some reduction in avoidable hospitalizations and improved dialysis care and reduced Medicare spending with this innovative model. Of course, we know about the January 1st, 2021 launch of the ESRD treatment choices model that incorporated, again, some of these attributes of the earlier CEC model to encourage both transplantation as well as home dialysis treatment modalities for patients with kidney failure. So that's the mandatory model. And again, this expanded really this view from the prior comprehensive ESRD care model to then really emphasize modalities beyond dialysis to include transplant as well as home dialysis. The newest model, the Kidney Care Choices model, launched in January 1st and builds on the prior CEC models, but also provides incentives for kidney transplantation. And so this is really the model that we're focusing on today, thinking about what is the role for transplant centers in this model? How can transplant centers really work together with these models to both improve access to care, quality of care for patients for end-stage renal disease, and improve access to transplantation? So I'm going to go ahead and turn it over to Tom now to go into the specifics about the KCC model and how it relates to transplant centers.
Great. Thank you, Dr. Patzer. Next slide, please. Great. So I just want to talk about kind of the overall goals and what we're really trying to do here. At a high level, from a CMS perspective, what our goal is to test out different models of payment and quality, with the goal of seeing if we take sort of our starting off point, you know, the existing payment system and the sort of how things are set up now, how can we adjust that and change that with the goals of getting the best possible care for folks with kidney disease. So what we're testing out here is it's a 5-year test to see if CMS sets these payment incentives correctly, will this have the effect of improving the quality of care for patients? So what does that really mean and what does that look like? One big goal is it's a single set of providers coordinating all the care across late stage CKD into ESRD and hopefully through transplantation. So a big goal of the model is coordinated care, working with nephrologists, dialysis facilities, and the specialists and the hospitals to really try to get the best possible care for patients. The next one, sort of multiple goals on the CKD side. Obviously, an ounce of prevention is worth a pound of cure. So I think one of the big goals of the model is to get a lot more, is to increase the quality and amount of interventions on the CKD side with the goal of later and better starts on dialysis for folks with CKD who are transitioning to ESRD. Another general piece is better coordination of care for beneficiaries. The biggest cost driver for beneficiaries with late-stage kidney disease like this, it's hospitalizations. And what we found in our previous efforts and from the literature is that there's definite opportunities to, I think, keep folks out of the hospital by greater investments in primary care and greater coordination of care among other providers there, that we think can really have the effect of saving money for the government and helping to improve the quality of care for folks. And then most relevant today, another key goal, I think as we're all aware, the best treatment for most folks with ESRD is a transplant, allowing them to live a pretty close to a normal life there. And trying to achieve more transplants and trying to reorient the whole healthcare system of nephrologists and dialysis facilities to get them focused and to get everybody focused on this single goal of improving quality of care and by trying to get more folks transplanted. And I'll go into it a little more about how we fit that into the legal structure of it all and how that fits also into the financial incentives in the model. But that is a key goal of the model, and it's backed up by some of the different mechanisms that we have built in. And then the sort of the larger principle with this and kind of our general goal here at CMS and CMMI is we want to align the incentives where if you keep patients healthier, if you get them transplanted, then you will ultimately make more money by doing so. We want to make sure that you get paid for keeping folks healthy and for doing what's best for the patients, and to encourage investment in those areas that can have the best effects for patients there. Next slide. So how do we do this? So we have it overall, it's called the Kidney Care Choices Model. That's our name for the overall model that stretches from that started in January 1st of this year and goes until the end of 2026. There's two different paths on it. So one is for nephrology practices only. So just testing out how nephrologists can do on their own there. Another one where I think a lot of the folks on this call can fit in is by bringing in other sets of providers there. So it's nephrologists working with dialysis facilities, working with transplant centers, working with hospitals, working with specialty care providers, and all working together to coordinate care. So ultimately, we are trying to test out both methods of care and do have sort of similar sets of incentives within both sides of it. But I think where we're most interested in, and kind of what I think we're trying to test really, is can we bring together folks working on the transplant process with folks with the nephrologists and dialysis facilities who are delivering and coordinating the dialysis care, and will that have the effect of increasing the overall number of transplants there? Next slide. So the way we do this, the technical term we use is kidney contracting entities. If you're familiar with ACOs, it's a very, very similar structure. So there's really only two required sets of providers, and a lot of different optional ones. So the first is the nephrologists. They're the ones serving as the primary care physician for the patients with late stage CKD and ESRD. And the goal is we're testing to see how effective they are at coordinating all of the overall care needs for the patient. One of the other keys to this model is that we're looking beyond just kidney related care, but also looking at hospitalizations and sort of any other care that the beneficiary needs. The second piece that we added in is we invented the term transplant provider, requiring each entity participating in the model to have as part of their network signed up the transplant provider. So we define that somewhat broadly. It means a transplant program, a transplant hospital, transplant surgeon, transplant nephrologist or nephrology practice, or an OPO there. So there's some of a lot of those different kinds of examples that are participating within the model. And I think what we're ultimately interested in is having some more folks come in. And we'll talk a little bit about what their function is. And we have Dr. Granger here from the Detroit area who can talk about sort of what that looks like on the ground. But in general, we just want to emphasize that this model is not just about coordinating dialysis care. Transitioning folks to transplants and doing post-transplant care is a critical piece of this model. And as a result, I think that's why we're looking for participation across the transplant community to really see how effective this can be. Next slide. So there's a few key functions that are kind of built into this overall role of that transplant provider. One is to serve on the governing body, to have a say in the overall governance of the KCE. And another piece then is you're required to receive a certain minimum amount of the transplant payments that will occur. The reason for this is that recognizing that even if it's not your transplant center or you are not the relevant transplant nephrologist, the real goal of this effort is to shift the overall orientation of nephrologists and dialysis facilities from just focusing on dialysis care to doing a much bigger focus on transplant care as well. So this is all a part of that important shift to bring a greater focus to the transplant process there. So those are the sort of the minimum level of requirements. I think the other goal then is to figure out how to guide the transplant policies of the KCE, to build the relationships within the community and help to ensure that the folks enrolled in the model are potentially good candidates. And next slide. So the way that we set up this model, and I highlighted sort of the most relevant part here for this call. In general, the goal is that this model focuses on patients where kidney disease is their primary and most important diagnosis. So we define that as CKD stage 4 and 5, as well as folks with ESRD who are on dialysis there. However, once a beneficiary is already enrolled and getting their care coordinated, and they're seeing the providers in the model, if they then receive a transplant, then they stay aligned and as a post-transplant beneficiary. And we'll get to what that looks like in a minute and sort of what that means payment-wise. But the point is that people post-transplant are a key part of the model. And this model is not only testing how effectively are we at getting folks through the transplant process, but also how effective are we, and is it possible to improve post-transplant care with the goal that once folks receive their kidney transplant, that they can remain healthy and off dialysis. Next slide. So payment mechanisms. So we have several different ones in the model, mostly related to nephrologist payments, with the goal of increasing reimbursement for seeing CKD patients, as well as some overall incentives for the model around decreasing the total cost of care and improving the quality of care. However, the key one that we're going to talk a little bit more about today is the kidney transplant bonus, which is a separate mechanism built into the model there to reward kidney transplants and getting folks through the transplant process. So the next slide there. So it's a total payment of up to $15,000 for every beneficiary who gets a transplant and keeps it healthy for the first 3 years post-transplant. Obviously, we'd love for the transplants to remain healthier for longer, but I think given the scope and timeframe of the model, we have a 3-year timeframe there. So the idea is that it's paid out the 3 years after the transplant occurs. So if I had a transplant today, the first round of payments would then go out March or Q1 of 2023, assuming the transplant stays healthy, and then 2024, and then 2025. And the idea is that the $15,000 total payment is split with $2,500 in the first year, $5,000 in the second year, and $7,500 in the third year. And the goal of there's sort of several different goals of these funds for what we're envisioning here. One is to reward investments in the transplant process. We recognize that it takes a lot of work from social workers, it takes a lot of work from care coordinators to really invest and support folks through the process there and to help cheerlead them through that process. Another piece is that we're doing this and kind of testing this out as part of incentivizing an overall financial shift away from dialysis care, which is what a lot of the current payment system incentivizes. So the goal here is to recognize that currently most nephrologists and dialysis facilities make their revenue by seeing patients on dialysis. Part of the goal of this payment is explicitly to help make a patient who gets transplanted a profit center, and to help orient and sort of incentivize getting folks through the transplant process there. The third piece then is recognizing that post-transplant care is important, and keeping the transplanted kidneys as healthy as possible is important. So we're really trying to incentivize post-transplant care by backloading the payments there. So these payments will go on for the life of the model there and are for every beneficiary who gets transplanted, even if it's not at your particular center or it was not necessarily your patient there, because the goal is that it goes to the whole entity as a whole. The other relevant piece is that a minimum of 20% of this, so a minimum of $3,000 over the 3-year period, must go to the transplant provider. That's only a minimum. It could obviously be more and sort of negotiated as part of this process, but we did set that up because we wanted to, I think, directly encourage folks to join in, and I think to reward some of the investments in the staffing and effort that it takes to help make this happen. The next slide. Great. Yeah, so just wanted to give that general overview, and I'll come back in a bit with a little more information about the model and potential ways to get involved.
Okay, so you heard why the process was set up, and I'll tell you a little bit about what it's like to be involved in it from a transplant provider standpoint. Next. So Secretary of Health and Human Services, Xavier Becerra, brought this up. Individuals with kidney disease who are able to obtain treatment early have a higher quality of life, and they're more likely to keep their jobs and be contributing members of society. This is nothing new to any of us in transplant. We all know this. Next. So I'm here at St. John Hospital in Detroit. We are one of, I guess, 5 transplant centers in Michigan. And I was, next slide, I was asked to be involved on the board of one of the 2 kidney care entities here in Michigan by one of the nephrologists and her group that was planning to join in, and they needed a transplant representative. And so they asked me to be that person. So I serve on the board of one of the kidney care entities, but it is not an exclusive process. And so our hospital is actually signed on as an affiliate of another kidney care entity. And one of our transplant nephrologists is the transplant representative onto that local board. Next. So for me, I just think that the best part of this whole process is just improving the relationships with the nephrologists and the transplant centers. We're learning more about how dialysis centers are assessed. I mean, I learned a lot the other day at one of our board meetings about how first starts are assessed, and all this is, I'm sure, secondhand, firsthand knowledge to all the nephrologists, but for me, it was all new, and looking at how they're graded. I got to see how Michigan compared to things nationally and things like that. Also, I've learned from both of the major dialysis companies here in the US, just the massive amounts of data that are collected, and a lot of the information that would save my coordinators infinite amounts of time. But I've also learned a little bit more about the financial pressures of kidney care. And the dialysis centers can learn, what constraints we have and what time constraints we have, and, manpower constraints we have, things like that. But also they get a better realization of the difficulties in post-transplant management and compliance, and the importance of truly being involved in that process. And so I think we both are gaining things from each other. You have to understand this model has only been active now for just a few months. So we're learning as we're going. Next slide. So all of this, I really look at it, as a transplant surgeon, as someone who deeply cares about her patients, is the goal of all this is really improve patient care. Yes, it saves money too, potentially, but really the ideal world for a patient is to not be in the hospital. And so there's a greater emphasis on home modalities, as he alluded to, which as a transplanter results in less dependent personalities. We all know the people that go to dialysis and stick their arm out and say, do it to me, I don't want to know about it, I don't want to think about it. And they're terrible transplant patients. And so with the greater emphasis on home modalities, you get a better feel for how are these people going to be involved in their own care. For people that are on home hemo, I, as a surgeon, love that they have better calcium phosphorus control. They have much nicer vessels. The transplants are easier, all of that. But there's also, for the first time, there's really a reward structure built for nephrologists to do better CKD care. Before, it seemed, at least to me as a surgeon, that people got paid to dialyze people, and so there wasn't necessarily that emphasis on early referral in that. But we're seeing people referred much earlier, and that just results in healthier patients for the time of transplant. But it also gives us more time to identify a potential living donor. Next slide. So, and really, I find that the KCE, the kidney care entity, can make the transplant center's job easier. With one of the groups, they have almost like a life coach, for the patients, because they want to get people through this process. They want people to show up at dialysis. They don't want them coming to the hospital to get dialyzed. And so they encourage the testing. So instead of my coordinators having to bug people all the time, would you go get your labs done? Would you go do this? They have somebody on the other side that's more invested in the process. And so we really find that that's been really helpful. There's someone to encourage compliance because, you know, the nephrologist now wants that kidney to work 3 years, just the same as we do. And so that's really helped. They also, you know, help encourage lifestyle changes. You know, I mean, it really is just having that additional someone to try to keep people healthy. And that because if they're not in the hospital, it saves the kidney care entity money. That would be more of a reimbursement for the nephrologist. And then also this massive amounts of data that the dialysis units get can be shared more readily. So next slide. So it's created a better partnership with our referring nephrologists, I have to say, even though it's you know, early in the process, because everyone's working towards, you know, better patient care, but early transplant saves money. But on our side too, we need to be more cost effective in our testing because, you know, total dollars spent or total dollars spent, making sure that they know the things that we can put to the cost report, the things that they should be, you know, doing otherwise. But it's also that we have an invested partner to help motivate people through the process. And this really helps save staff time. And to be honest, the nephrologist gains if the transplant does well. So they don't want to be sending us people that they know are not going to do well. They want to work with us. And so this has really been exciting. And with the groups, we can go to the next slide. So with the group that I'm on the board with, we have monthly meetings that were with other transplant providers from across the country. We have, they've made available to us resources for helping with things like living donor navigators, kind of standardizing, you know, seeing how other centers do their testing algorithms and things like that. And more importantly, just getting real world examples of how we can do this best. And we really, I've really personally found that those sessions with the kidney care entity really are encouraging best practices across the country. And we really find that really encouraging and really helpful. So next slide. So I don't really have a lot to say other than it's been a really great experience so far because it really starts as this partnership with the nephrologist and the surgeon, the transplant centers as, you know, a partnership in patient care. It's also obviously given me greater contact with our referring nephrologists. We've been able to do some things for them too. One of the payment changes is that if you give education about transplant, you know, the same way that you give education about dialysis, you can be compensated for that now as a nephrologist. So we've provided them with information that's helped them too. We have seen an uptick in referrals. I hope that continues, obviously. But really we have a better understanding of each other's issues. But what it really it all comes down to is it has great potential for improved patient care, and my coordinators potentially his lives will be easier as we have greater sharing of data and this life coach kind of thing that that we don't have to spend all this time trying to track down patients. And so that's what we've really found. So next slide. And I'll turn it back over to Tom.
Great, thank you. So I wanted to talk about sort of where we are in the model and sort of how folks could potentially get involved. So where we are right now, this is the KCF. These are the nephrologist only ones. And these are, we have 30 across the country with about 10,000 beneficiaries and about 300 physicians. I'll also add with this that we're in the midst of a solicitation that ends tomorrow. So there's sort of, all of these numbers are obviously subject to change there. So these are the ones that are nephrology practices only. So I think these are a little bit less relevant here. But if we go to the next slide, we have 50 KCEs right now across the country with about 2,400 nephrologists, about 200 transplant providers across the country, about 2,000 dialysis facilities. and close to 120,000 beneficiaries there. And that also includes then, and this number will, hopefully go up with this solicitation here. So what I want to do is, if we go to the next slide, I want to show this map where if you see these squares, this is where there are kidney contracting entities around the country. And it's a pretty good geographic spread. No, not so much in the Mountain West, but in most of the rest, or New England really, but most of the rest of the country has participating entities there. And what I think my big pitch is that if you're in any way close to these areas geographically, I would strongly encourage you to reach out to the relevant folks who are operating and running these groups, just to talk with them and kind of hear about what their plan is and how they're doing this. The beauty of this model from the transplant center and transplant surgeon perspective there is that most of the work, the administrative work, the dealing with CMS, the worrying about care coordination for CKD and ESRD patients will be done sort of elsewhere by some combination of the nephrologist, dialysis facilities, and sort of other providers that are already built into the entity. So there's a freedom really for, and sort of an incentive there to focus more than on the transplant piece of it. And I think, honestly, the more transplant providers in the community who are involved, then I think the more effective it can be. So in an ideal world, let's take the one that's in the greater Atlanta area. We have a kidney contracting entity in that region. So in an ideal world, if they were really sort of working with all of the possible stakeholders to coordinate care there, that hopefully that would be the Georgia OPO and all of the relevant transplant centers in the Atlanta area, as well as whatever relevant transplant nephrologists are kind of the key referrers there and who they've worked with. In an ideal world, all of those folks would be part of the entity. Obviously, it's probably not, 100% is not ever really going to happen. But I think the goal is to really try out more and to really test it out just to see, does this care coordination and payment structure, and can that lead to more transplants for the beneficiaries there? So if we keep going on, we're going to zoom in on some of the regions here. So you can see just some of the local entities here. You can see the ones in Detroit that Dr. Granger is a part of. And these slides, I saw that Brian from AST posted that they'll be available there. But we strongly encourage you to sort of look at them and to go to our website where we have sort of more detailed information about each of the participants, including contact information to reach out and connect with the folks in those markets there. So that's really my pitch here, is just to begin that conversation. We have pretty good levels of participation from all major dialysis companies, from different care coordination companies, from thousands of nephrologists across the country. And I think with that level of engagement, we'd sort of love to get a significant slice of the transplant community involved in here, if at all possible, too, to serve on the board, to serve as the transplant providers, and to receive at least some portion of the payments that go out there. So here's, the zoomed in maps of the West, the Midwest, and the Northeast. And the next slide. And then very heavy penetration in the South. So we are doing a request for applications that's going out and due tomorrow. So there will be a lot of new entities joining. But I think what I would encourage folks to do would be to talk to the local nephrologists and talk to maybe the local dialysis companies there, and just begin the discussion just to sort of check the map and see who is participating and kind of what their thoughts are, to see if it's possible to join and be a part of it. And I'll say on the CMS side, we're sort of happy to help, to explain, to answer questions from folks. If you email us, and we have an email coming up later that we'd recommend folks send it to. And the next slide. So this is also where I want to, now that I have you all, just to make another pitch for another one of our efforts that I'm sure a lot of you all are involved in there. For another model we have that's a little more focused on home dialysis and encouraging home dialysis and transplant waitlisting. We have the ETC Learning Collaborative, we call it. And this is really aimed at transplant centers and organ procurement organizations. And the goal of this is encouraging greater utilization of kidneys, to encourage improved OPO performance, and to encourage increased use of marginal kidneys that are higher KDPI. And so the goal is to kind of share best practices across the country, and with the goal of overall quality improvement here. I bring this up because there's a lot, the goals of the collaborative are, I think, very closely linked with the goals of the Kidney Care Choices model. And sort of what we're going with as CMS is really trying to align all of the relevant incentives for folks to really push the whole system to getting more people transplanted. So we appreciate whatever participation folks are doing in the Learning Collaborative. And hopefully this can really increase the supply of available kidneys there. But I think just wanted to highlight this one as well, given that it is relevant there. Great.
Great, fantastic presentations and talks. And now we'd like to open up the Q&A. I'm gonna go ahead and close these slides, and please enter your questions in the Q&A, and I will get to those in just a second. Oh, you've got it for me. Thank you. Okay, so let me start with a question for Tom. It's a question by Dr. Roy Bloom. Since any board certified nephrologist can practice as a transplant nephrologist without any additional transplant specialty training, how do you define a transplant nephrologist in the context of the kidney contracting entity? Oh, you're muted.
Yep. We use self-identification, recognizing that it is a somewhat amorphous idea, but it is recognized as separate from a treating nephrologist, and beneficiaries. The beneficiaries who they see, if they also see CKD and ESRD patients, are not aligned then. So it is done through self-identification. Yeah.
Okay, and another question from Dr. Wiseman. Can you give examples of cost-effective transplant-related testing that you're considering? So I think, Darla, can you address that?
Yeah, some of it is, you know, we found that the nephrologists were very enthusiastic and wanted to just have our whole list of tests and get all that done. But some of it really should go to the cost report. But the bigger thing that we've started, you know, looking at, which I know other centers have done previously, is rather than getting a bunch of tests up front, knowing that people are going to be waiting for a while, if they don't have a living donor identified, that waiting on some of that testing until, you know, till that's more appropriate, doing more eyeball testing, where if somebody's, you know, frail and you're not certain that they're going to be a candidate, maybe doing some other testing up front, as opposed to someone who's healthier, but you know they're going to be waiting for a while, then holding off on some of that testing too. So some of that, and then just reassessing everything we test. I mean, it's like, does this really make a difference, you know, or is this just historic that we've always done that, you know, trying to look at things, you know, in a continuous fashion.
So, and another question from Dr. Gibney, is the 20% of the transplant incentive shared with the treating center or the transplant representative that is part of that KCC? So Tom, is that up to the KCE to work out those details, or is there something specified in the model?
Yeah, so it's only for people who are participating in the model as part of the KCE. So it could be the center, if the center is in the KCE and is the official transplant provider there. But if the transplant center is not in the KCE, they would not get any of that portion. They would still get their normal Medicare reimbursement there, but they would not get those extra payment incentives. And we do that, so it's only for folks participating in the model there.
So Tom, even
and I'm an employee, so I mean, it goes to the hospital, you know, so it's, I don't get anything out of the deal.
Except for the good for the patients.
Exactly.
So Tom, but so, you know, elaborating a little bit on that. So the if the transplant center or a transplant provider is part of the KCE or the kidney contracting entity, the 20% incentive to who dictates how that is split between the nephrology practices and the transplant center or the transplant nephrologist? Is it the model, or is that part of each individual KCE determines that? Can you clarify that?
Yeah, that's determined within each individual one. We do try to give discretion there, recognizing that, and leaving space, frankly, for kind of innovative payment ideas or I think figuring out where to best prioritize it. We did just sort of set aside a portion of that payment, though, must go to the transplant provider. And that's kind of our minimum level requirement there. It also could be more than 20% there. But we sort of view that's all part of the relevant negotiation and enrollment process there.
Got it. So do you have an extent that you could describe of the existing KCEs, what your sense is of how that works? Is there a lot of variability for how the KCEs are handling that payment?
Yeah, I mean, and actually this is where Dr. Granger, if you maybe want to talk about that, how that's gone on, given that you are the recipient there.
First of all, it's early, to see that. I don't think we've seen any of the payments yet. But as I said, I'm an employee, so the share that I would have from that, that would go to the transplant provider on the board would be going to my hospital.
Yeah. And just to add on there, the idea is just to recognize that I think folks do have to sign an agreement with the KCE that kind of lays things out, and sort of means that they'll follow the rules that CMS has set up for the program. So there is a legal component to this that obviously can get complicated with large hospitals there. But once all of that is worked out and everything is negotiated through, then you can be a part of the.
Yeah, the attorneys had a time with the contract before we started.
Yeah, there are a few other questions related to, I think, some of these specifics, but I do want to ask you a question, Darla, around just the administrative aspects of this and, how much time it took to set this up from the transplant center's perspective, knowing how busy transplant centers are.
From the transplant center, all I had to do is make sure that the contracts got sent to the attorney. And then I have, as the member of the board, I'm expected to attend the board meetings, which are usually in the evening. From a logistics standpoint for my staff, I think it's really a wash, because if we try to keep in contact with the referring nephrologist anyways, that's no different. And it's just the benefit that we get some data we get more data. The dialysis units are more helpful, I would say, than they had been in the past. Let's put it that way. And so it's made it easier for my staff time.
Got it. And maybe I'll ask one more question around it seems like there's a lot of questions around payments and how does that 20% work? One more question on that, and then I want to turn to another topic. So if there's an OPO, multiple transplant centers, multiple transplant professionals that are involved in the kidney contracting entity as part of this KCC model, do all get the possible 20%? And I think I know the answer to this. No, but I don't know if you want to add some context there.
Yeah, I think I would just say it all goes into what's negotiated out with the KCE. We as CMS set that minimum dispersal requirement, which works out to $3,000 of the $15,000 there. And that could be split amongst different folks depending on who's enrolled there. So that is a minimum amount, though, and there's sort of definite opportunities to exceed that in negotiations and discussion with the KCEs there.
But I think you also have to keep in mind that it's the nephrologist taking the risk. This is a shared risk model, and the transplant center is not involved in the risk because they're not our patient lives. They're the nephrologist patient lives. And so for the transplant center to think that they're going to take all this money from them would be kind of ridiculous, I think.
Yeah, that's a really good point. And I think this is related to a comment and a question by Dr. Ben Hippen too, really asking clarification from Tom for the audience that transplant provider members, specifically the transplant center, of the kidney contracting entity in a professional or global CKCC model, they're not subject to this downside risk on iterative total cost of care calculations, unless that risk is negotiated as part of being the transplant provider member in that KCE entity. So I think that's important, because I think that seems like there's a big misunderstanding from transplant centers about that downside versus upside risk. And it seems like there's more of just the upside risk here, right? The opportunity to get some of the benefit from it, not the risk. And I think that's an important point. Do you want to comment on that and clarify, Tom?
Yeah, that's correct. And thank you for bringing that up. I think what I'd add to that is that part of what this model's a lot of what this model is testing is how effective can these groups of docs be and everybody be at coordinating the care and reducing cost for CKD and ESRD patients. But once you get somebody transplanted, we know that saves money for CMS on average. Obviously, transplant costs are highly variable in the first few years. So that's why we just did it as a set amount there, upside only to be distributed out over time, because we're not going to try to account for surgery costs and recovery time and all of those issues. So yeah, transplant is an upside only opportunity there.
Great. And then one maybe quick question for you, Darla. This is a good example. Maybe you could walk through it, but a question around, can one transplant nephrologist or provider group participate in multiple kidney contracting entities? And I think this is a great illustration.
Absolutely.
Of you're doing it.
Yeah, I mean, there's nothing that's exclusive, other than I'm not supposed to share the secrets of Dr. Hippen with the other side or whatever. There are, conflicts of interest, things like that. But no, I mean, there's no downside. I mean, we have a number of nephrology groups in the greater metropolitan area, and each group decided to sign on with one or the other of the entities. Not all the nephrologists did, but I have to say a huge proportion of them did. The ones that didn't would be like the people at the University of Michigan or the people at Henry Ford. They didn't sign on, but for the independent nephrology groups, most all of them did. And so we work with both of them.
Okay, so I want to answer one of the questions too from the chat. It's a little harder to monitor all the questions in the chat. If you could put that in the Q&A, it's a little easier to manage. But the genesis and origins of the KCF and KCC models, and I want to combine that a little bit. I introduced the background of this with the comprehensive ESRD care model and knowing that there's some similarities, but wondered, Tom, if you could take that on and think about what has CMMI learned from those previous comprehensive ESRD care models that you've incorporated into these new models. So thinking about sort of genesis and origins of this, what have you learned to then expand to transplant here with these models?
Sure. So I think there were several learnings. So the CEC model, the one that ran from 2015 to early 2021, it was ESRD beneficiaries only people on dialysis and based around the dialysis centers. So we made this model, the sort of successor one that started in 2022, is a lot more nephrologist centric, and it's based around nephrologists there. It includes a much broader spectrum of care. So we got strong feedback about the need to include CKD beneficiaries to really help improve that transition and the before care. And then also that the CEC model didn't have any change on transplant rates. So we're sort of hoping by putting in these extra incentives and including these extra requirements that there can be some opportunities to, I think, work through a lot of the challenges around transplanting folks.
That's great. Thanks, Tom, for clarifying that. I want to talk a little bit about some of the models and how you will evaluate success here. Of course, we see success as when these patients will get a transplant and have good graft survival after that transplant, but how will CMMI evaluate some of that success? And thinking about the models in particular, metrics of success, how might you take into account differences in patient populations, for example, risk adjustment? Can you talk a little bit about that?
Sure. So Dr. Hippen put in the chat our full evaluation report that we conducted for the previous model. So basically, we go through a very statistically rigorous independent evaluation team that sort of conducts a separate evaluation of how the model went. They do look for matched comparison groups, comparing outcomes relative to the fee-for-service population there. And we'll also look for outcomes relative to the other primary care models, to some of the other programs that CMS is testing. There's a lot of different answers. So one answer, I mean, our mission is to try to reduce costs and improve quality of care. So there's a lot of, and this is a complex model with a lot of different pieces. There's the nephrologist payment parts, there's the CKD parts, there's the care coordination parts, there's this transplant part, there's the use of the kidney disease education benefit. And I think, honestly, we just want to see how everything works and see which things are really affected. I think in CEC, we saw definite statistically significant results around reducing catheter utilization and improved hospitalization rates and improved adherence to dialysis. And what that told us was that okay, these were good statistically significant results and were clear focus areas, but it showed that there were areas that could definitely be moved beyond. So honestly, like if you read the report, which is a good read for everybody, we track a lot of different figures, but in general, it's relevant to a matched comparison group there. And we're really trying to conduct a pretty rigorous statistical evaluation to see how did this affect cost and quality of care and attack that from as many different angles as we can.
And one quick follow-up, Tom, can you clarify how attribution works for this model? Is it at the kidney contracting entity level, or is it at a different level, sort of based at the practicing nephrologist level or a dialysis facility level? Can you clarify sort of how that's evaluated? Yeah.
So the way we set that up is based off of who patients that nephrologists see. So for CKD patients, it's twice within a year with a diagnosis of CKD 4 or 5, or 2 monthly capitation payments within a 3-month period for ESRD patients. And then they are attributed to the larger entity there for all of the participating nephrologists there. So technically it's because we're really testing how effective the entities are at coordinating care. So it is technically to the entity level, but it's based off of nephrologist care relationships and who the primary care nephrologist was.
Got it. Thank you. And then maybe a question for Darla. I think you emphasized this a lot in your talk around just the really large benefit of this connection between what I think are really typically siloed health systems, dialysis facilities, CKD clinics, and transplant centers. And it sounds like some of the, even though we're just a few months in here, some of the, what you consider successes so far are this increased communication between all of those providers across these health systems. What I wanted to talk about is, or ask you about, was around just what do you think so far, some of the plans for what you're doing next? What do you think is the most promising? Are you taking from those conversations? Is it the conversations at just the level of communication across the systems that you think will make the difference? Is it you want to implement a new program, or you're discussing implementing new programs like a living donor care navigator? What are the types of discussions you're having around what might really change care? What might really increase access to transplants?
Well, with the living donor navigator, we have a person designated for that. But to be honest, that role was a little bit floundering. And Dr. Hippen was kind enough to come and give grand rounds for a transplant conference for us and give us much better insights in how to use that person much more effectively. And then when we were talking about that at the board meeting, then a group of nephrologists who hadn't traditionally been referring to our group found that very exciting. And so now we're working with them more and working with their dialysis units where we never were before, things like that.
Great. Another question, maybe back to you, Tom. So, we know there's a higher burden of disease among minorities, among patients with lower income, and that these patients have reduced access to transplant. In July of this last year, CMS specifically proposed changes to the mandatory model, the ETC model, to address health and socioeconomic disparities. But I'm curious how equity in access to transplant is being considered in some of these voluntary models, and in the KCC model in particular, relevant to transplant access.
Yeah, I think that's something we're definitely evaluating as part of the model, just to see the effects, to see where things come up, and do some thinking about if we need to adjust the incentives in any way there. I think that is a critical piece. I'll also say that part of the point of this model is that it gives these entities a lot more tools, I think, to help out patients, to offer services, to offer transportation, and really deal with a lot of the social determinants of health that I think can really prevent access to transplant. Like, I know transportation too many transport words, transportation is obviously a huge barrier for a lot of folks. And one thing we saw in the previous model and in this one is a lot of investment in transportation services, so that folks can get to all of the appointments that are required to for the pre-transplant checkups. And so
getting a colonoscopy is like a big holdup for us, and transportation for that is huge.
Right. Well, I would think that there's also opportunities just with that increased communication between dialysis facilities, CKD clinics, the referring providers, and transplant centers on what those barriers might be and how you might address them. I know these are conversations we've had in our local area where, you know, something like the requirement of transplant centers to have a every 6 month dental exam, for example, was a barrier to some patients. And talking about removing that as a barrier has helped improve access. So, you know, Darla, is there any discussion amongst your group and your kidney contracting entity around that effect? You know, what you might be able to do to improve equity?
Well, I think that you know, the whole concept of the life coaches, where there is a financial incentive for the nephrologist to make sure that people get to dialysis at a center and aren't doing it in the acute unit in my hospital. You know, there's just helping people problem solve, I think. You know, where before it just kind of seemed like it was reflex. Well, they missed their appointment because their ride didn't show up. Well, we'll send them to the ER or something like that. And so now there's a financial incentive for them to do that, which gives people better care. And it kind of helps people be a little bit, you know, more engaged in the whole process and things like that too. And I don't know, we just see that people are more engaged, and people that do home dialysis, they just make better transplant patients because they've had to be involved in their care, you know. So I think the idea that we're going to give people better CKD care, we're going to give better people, you know, more home modalities from a transplant center, that's huge. And that, but and then for the people that still have to be in center because they don't have space to have all this stuff at home, you know, that we'll be supporting them better because there's a financial incentive to do so.
That's great. Thanks,
we get paid for doing what's right. It's kind of cool.
And maybe just, we may have time for just one or two more questions. I know we're getting towards the end. Another question here. By definition, transplant recipients all have end-stage kidney disease and have increasing medical complexity with time post-transplant. In order to incentivize better long-term survival, I wonder whether a payment model similar to chronic kidney disease or dialysis care may be a better incentive than a bonus for the first 3 post-transplant years. Tom, do you want to tackle that one?
Yeah, I'll say it very well could be. I think we're kind of testing this out, sort of this incentive structure here, but I think part of what we're going to look at is effective post-transplant care. It's really the costs are very variable for that population, where it can be very high, like especially, you know, year one. And it makes it difficult to kind of set any kind of cost benchmark there. And I think that's something we're kind of looking at and considering there, but we're just really trying to keep it somewhat simple in structure here. The incentive somewhat simple, just recognizing it's a very complex set of patients with a lot of different needs.
As a transplanter, I'm just so excited that people get coverage longer than 3 years for their transplant meds. I mean, I'm a simple girl. I just take my wins where I can get them.
Yeah, I'll also say that hadn't passed Congress when we first were kind of designing and implementing the model there. And it's obviously a great policy there.
It's great. So we just have a minute left here. Any last words that you want to share, Dr. Granger?
I mean, I just think that the key thing to this is, I just look at it, there's some upside and there's really not downside. I'm not putting, dollars at risk like the nephrologists are. So I think that from a transplant center standpoint, there's no reason not to be involved.
Great. Tom, any last words?
Yeah, if you could maybe put up that last slide that I had.
I can try.
Okay, yeah, and if not, that's totally fine. But yeah, my last words are, please go to our website and look at the list of participants there. Did I have a last slide? Maybe I didn't.
Got it?
No, I had one. Okay, never mind. Sorry. Basically, if you go to our website that's listed in the chat there, as well as the document that was put into there, the other link that was just put into the chat, where you can see the list of participants. I think we're happy to sort of answer any questions that folks have. So feel free to email us, feel free to look at our website, feel free to look at the participants. So thank you.
Great. Thank you all. And AST.
Thank you, Dr. Patzer. AST would like to thank Dr. Granger, Mr. Duvall, and Dr. Patzer, and all of our attendees for today's session. We'd also like to thank the AST, KPCOP, and Transplant Administration and Transplant Administration and Quality Management's Community of Practice for their support for this session. Please remember to complete the evaluation survey and visit the AST YouTube channel to view our video archives. Thank you all again for today's great session.